Okay, well, we're waiting for our audience to come in. I'm Kevin Poor, and I'm the director for Substance and Addiction Services for the Deaf, SAISD, and that's here at NTID in Rochester, New York. And before I go ahead, I do want to give you all just a quick reminder about this evening. Please don't turn your cameras on. We don't need any interruptions like that. If you have any questions, feel free to type them into the chat, and that will be sent to the hosts and panelists. That way, everybody won't see it, just the hosts. And we'll also have the opportunity to have a Q&A at the end. Let me read that chat. Hold on one moment for me. Okay. Yeah, the Q&A will be at the end. You can click the Q&A at the bottom, and that should work better so that we can get everybody's Q&As. And once we go along, we'll just kind of have this chat together, and I'll be checking out the chat. If anybody sends in any questions now or later, I'll be monitoring it. And this talk will be about for an hour, maybe 40 minutes, maybe to 35 minutes, and then we'll turn it over to questions. I'm going to go ahead and share my screen now. Let me pull that up. It's a PowerPoint. And feel free to maneuver your screens however you would prefer, all right, so that you can see me and the slideshow as well. Okay, so this evening, I was invited to speak with all of you through the Deaf Health Talks. And this is about substance use disorders within the deaf community. The word substance use disorder, it's a more current and appropriate term that could be used for alcohol problems and addiction. In the past, we used the word dependency and abuse, and now a more current term is SUD, substance use disorder. And I'm going to speak about how SUD is involved and diagnosed within the deaf community. And so here we run on campus for the SAISD team, and we have since 1979. It's obviously not been myself the entire time. I've been in the position for 5 years, and I've been operating the program with 5 positions, and one has been empty for a while, and it's been the 4 of us that are pictured here on the screen for quite some time. The next slide will show what we typically do on our daily services. So really, our goal is to prevent. We are a prevention program, not a treatment program. We don't sit down for weekly discussions with our clients. We're not licensed that way. We don't counsel, we only teach. We teach youth, as in college students, as well as the deaf community at large, about drug and alcohol information. And that is helpful for the deaf community to make good decisions.
about their use of drugs and alcohol, whatever. We are not a program that says, oh, you should never use, you can never indulge in these things at all. We just give knowledge because we believe knowledge is power. And our goal is to educate and teach. Sometimes we do sit down with students here at RIT because maybe some students have some concerns and they're not sure if they have a problem or not. Perhaps they have family problems or other issues with drugs and alcohol dependency and abuse. But we sit down with them and have a talk and see if we could refer them out to another more appropriate service program. It's great because one thing we'll cover later is that there is a discrepancy or not a disparity in the use of sign in that realm. So here in NTID, you know that we have college students that sometimes can get into some trouble, and the college has rules and policies that are related to drug and alcohol use, and sometimes they will refer students to us if they think that there is some sort of problem, and we will attempt to intervene and help that student gain the knowledge that they need to make better choices. And if they need more in-depth help, we will of course refer them. And we do provide counseling in our impact program here in Rochester. If a deaf person shows up there, we will send our counselor there. And that's about 20 hours a week. We provide that service. And deaf patients can go and speak with a deaf person in their native language instead of using an interpreter. So our goal is to advocate as well. Sometimes a program has no idea how to appropriately provide access to deaf and hard of hearing people. We tend to encourage that they get equivalent services, not writing back and forth or using a language that is not their own. Someone's asking me to spotlight the presenter. Let's see. Okay, so that basically summarizes. We are on Facebook and we have a website as well, which you can see here at the bottom, our QR code at the slide. Please do join our Facebook Lives if you'd like. We do upload frequently with different articles on awareness and information. This month of August is actually overdose awareness. Oh, give me 1 second. Yes, overdose awareness month, which we're currently in August. So we have different posts that we put up, different videos that are in sign language for people to view. The QR code brings you to our website. I would like to share some statistics and a bit of information about what's going on with our youth. And when I say our, I mean deaf and hearing, just the youth of the world. Unfortunately, we don't have any information about the deaf and hard of hearing statistics. If you know, please do refer me to that because I'd love to check it out. But unfortunately, we don't have any information on that specific demographic at this time. Currently, our priorities for issues are vaping, which is something I'm not sure if anyone has a different sign for it. I just use several. And the statistics here on this chart show from 2015, because that's when the vaping was very new, until 2019. It showed about 50% of high school students have already touched a vape once or more, at least once. 50% of students have already experimented with a vape one time. It's probably out of some curiosity, but that's 50%. For example, me, myself, Kevin, I have never, and I'm being honest here, I have never touched a cigarette in my life. Growing up, I never had any interest. And so that is a bit more rare. You know, people are usually interested. They will kind of try it out and then drop it when they're not interested anymore. That's not a very in-depth statistic, but I think it's important to share. There are some things in the chat about some different topics tonight. Okay, all right. So the percentage of high school students, like I mentioned, as a whole, during a survey that was sent out, they checked some boxes to kind of document how many percent had used a vape or e-cigarette. And here are the statistics on that survey. So in total, it showed how many currently use, and that was 32%, which you can see here. And the most increase was in the 9th grade onto the seniors. So you can see there was an exponential increase there, as well as age, race are also shown in this: Black, Hispanic, white, etc. Male, female. And that's just for, like I mentioned, vapes or electronic vapor products. This graph is showing more about drinking. This was a survey that was, again, distributed to youth all over the nation. In 2019 was the last time the survey was sent out. And this is a total from the year 1991 until 2019. And you can see there that there seems to be a slow decline from 51% down to 29% currently. So we do have a 21% decrease that we've seen over the past years, which is good news, meaning that teaching and knowledge sharing and giving people the opportunity to learn and make better decisions has been working. Some states are starting to allow cannabis. And the question is if people are transitioning instead of using alcohol into using cannabis, but that's something that's still being studied. Of course, we are continuing to educate. And it is still quite serious at 29.2%. Okay. So marijuana usage, cannabis. Who currently uses is the question on this survey, and now is documented. You can see kind of an up and down starting in 1991, heading over into the early 2000s and into 2019. And this is, again, high school students. You could see that there's not any sort of exponential increase or decrease, but perhaps that will change because there are more opportunities because of the legality. New York State, for example, cannabis is becoming legal. It is new, and that is being navigated at this time. Okay, I'm just checking the chat, making sure nothing is directed at me. It seems not. So, okay, now on to the next slide. This one discusses how likely a person is to become addicted or diagnosed with SUD and what the reasons are behind it. Give you a moment to read here. And so people who start drinking alcohol around age 15 or before the age of 15, their chances of becoming addicted to said alcohol having a serious problem as an adult and acquiring an SUD are higher than 50% or around 50%. The older you are the first time you have your first drink, the chances of addiction decrease. So that means that at the age of 18 to 21, if you have your first drink, it is less likely that you will become addicted to alcohol. Now, it is very important that our youth are encouraged to prevent that first time of drinking alcohol. Of course, people will be curious, but we hope that they will choose to wait until later in their lives. And we do encourage them and educate them. And if they have already accepted drinking into their lives, we try to give them some other options to enjoy themselves. So that's just some general information about people who are both hearing and deaf. It's more of a factoid than something that's more focused. So I'm going to now get into a bit more targeted discussion about the deaf community. So the question is the deaf community different than the hearing community? And I'll get into that now. Just seeing if there's a question. Is this just in the US only, or is this a global survey? These statistics that were shared here in this slide are local in the United States. I'm sure you could apply it to other countries, but their approaches and their philosophies and their attitude about alcohol may be different when you get into different cultures. Some people say that, you know, kids can have a beer or a wine in Germany, in France, with their dinner, they can have a drink of alcohol. Does that mean they'll become addicted? No. And the reason behind that could be researched more. Okay, and I see another question here. The statistics I recently shared, was that for the deaf and hard of hearing community or the community in general? That is a survey that was done to the general public. We're unaware of how many deaf or hard of hearing people were included in that survey, but my goal is to have a survey that is similar, but more targeted on the deaf and hard of hearing community, so that we can see what our needs are for providers and researchers. We do need more data and numbers to show to those who provide funding for these types of programs. So now we're going to discuss the deaf community. I'm not going to share any statistics, but I'm going to share some observations and some of my own experiences about what I know. So I started working in this field when at the Minnesota Chemical Dependency Program for the deaf and hard of hearing. And that was established in 1989. And I was one of the first staff there. When it opened, I was present. And Linda Bove, the actress from Sesame Street, she was actually there for the ribbon cutting. It was a huge ceremony on March 14th, 1989. And I do remember that. I've been involved with this field since that time. And I have seen and learned and discussed a lot. And this is more about what I've noticed in the deaf community in regards to SUD. Okay. All right. So again, we have a lack of substantial data. We've had a few local surveys just asking general questions about people's experience with alcohol, marijuana, etc. I think that we had one larger survey that was more of a general health survey from somebody in Gallaudet several years ago. But I'm not sure how much data that survey actually had in regards to drug and alcohol use. So we do need more information to help us have a solid decision about where to put our time, energy, and effort. If we should focus more on treatment, or if we should focus more on prevention, or maybe a mixture of both. But we do believe that the hearing and deaf demographics might be similar. In general, about 10% of the population has an SUD of some kind, about 10%, and we assume the deaf community may be higher. My assumption is maybe around 13, 12, somewhere in that realm. And I will explain the reason why I believe that. I believe we have a lack of information, lack of services, and lack of support as well.
So those individuals who have been drinking alcohol, not everyone becomes addicted just because you do drink alcohol. There's a portion of them, a percentage, who develop a serious SUD. And it's alcohol use disorder, about 0.6. But maybe if we apply it to the deaf community, I think that would be statistically about the same. Again, maybe a little bit higher for the deaf community. When we're talking about illicit drugs, illegal drugs, opioids, marijuana, crack, cocaine, any other medical drugs, then that's about 25%. So that leaves us, when we talk about people use it, again, we need to remember we're talking about recreational use as opposed to having an addiction or a disorder with it. So roughly about the same within the deaf community and the hearing community. But knowing these statistics does give us some information to work with. When we're talking about treatment, we know that people need help and we need to make adjustments. We need to find a way for them to adjust their lives to either abstinence from drugs or alcohol, or at least being able to lessen the use of it. If there's a struggle and it's something they can't do on their own, then of course, in going to an inpatient treatment, possibly joining an outpatient treatment program, something more intense that would be used and would match that individual's specific needs for what they have. If we're talking about residential, that would be an inpatient. There's also halfway houses that are kind of inpatient, but throughout the United States, there are about 350 million people. I don't know what the statistics are at this point, but out of those 350 million people, there are 4 residential inpatient friendly for the deaf community that is able to provide the services that are needed for those individuals. They have staff who can sign, or maybe possibly not great at signing themselves, they're not fluent, but they do have the knowledge of working with interpreters. And again, we're talking about 4 inpatient types, 4 inpatient services for them. There used to be more in the past, but again, there has been a decrease in the services. There's maybe 10 or 11% that is alcohol help, but where are we talking about with the drugs? When we're talking about the options for getting services in other locations, in other instances, there are so many barriers that the deaf and hard of hearing community experience that is very unfortunate. And it's something we've been watching for the last 30 years. I myself being involved in the community for the last 30 years. We continue to try and elicit awareness. We try to get the community to understand the benefits of treatment. We try to get people to understand that they go back to their lives to have a reconnection with their families, with their friends. Again, when we're talking about the deaf community, as an individual who grows up in a residential school or in mainstream school, we have to wonder what the level of education they've had, the terminology they've had in regard to alcohol, in regard to addiction. Do they have the big picture for what they're seeing in the community? They really don't. That is impacted, especially when we're talking about language access and having a struggle being able to understand that. The fund of information is not there. There's a lack of information. There's so much information that is, what percentage, we don't know, but within that, the information that is being relayed, we don't know if it's 1 out of 10, 2 out of 10. We don't know how many individuals that do not have the awareness of what's going on. Many of the deaf individuals that I've known, hearing individuals as well, but they think, no, I don't have a problem. I'm powerful, I'm strong myself, I have my own resistance, I control myself, everything's good. This is not a problem for me. It takes a lot of education and encouragement to really open up their minds, to make sure to see that there is a problem out there, that there is a cause for where they are and why they're doing what they're doing. When people get together for events, everyone drinks, things happen. And so you gravitate them, you join in because you don't want to be looked down upon. You don't want to be the outsider. So people conform. There are many reasons why people do drink and then possibly disregard that there could be an issue there. They don't see it within themselves. And they believe that it's not possible. It's not me. I just have no big deal. I have a drink. That's not going to hurt me. I'm sober now. I don't have anything. I may have one drink. But the understanding of where one drink leads and being able to educate individuals and let them know is something we still need to work on. The information in regard to print material, information, ads, catalogs, flyers, many of them are not culturally appropriate to the deaf and hard of hearing community. A lot of the print material, the books, the prevention catalogs, the curriculums, everything that's out there is designed for the hearing community. The deaf and hard of hearing community is not considered when those things are being able to be disseminated. They're not thinking about how it would help if we could change that or adapt that for the deaf and hard of hearing community. So at a point, there needs to be an adaptation to the materials for the deaf community. Many people who have taught within talking about treatment, talking about abuse, talking about SUD, we are prevented ourselves being able to get information and being able to get it out there. We need to rely on interpreters for any workshops, for communication that we have. They're not deaf friendly. So it's very different, it's very difficult. And we understand that as educators ourselves, sitting in a location where you're not having access to all the information. So when we're talking about that, we need to think about, we need to match a style for each person as well. It's not a one size fits all. We need to have time one-on-one to talk with individuals. And that's something that we need to continue to do. SUD within the deaf community again, the number of barriers is astronomical. Of course, one is financial, lack of understanding. Even the family themselves, if the parents are not understanding, if their child is having a struggle with drugs or alcohol, the parents just believe that they can handle it themselves. They'll take care of it. So that in itself is a barrier. And that's not the point, is that the child doesn't need you, or that you can handle it yourself. The point is that the child everyone needs to have access to the information. They need to be involved with others to be able to keep themselves from continuing use, because we know that it comes up again later on in different instances. So it will there needs to be other interventions within their lives, because it will show up again later on in different situations for them without the understanding of what's happening. And understand, please, that the deaf community has the same struggles, but I apologize, the interpreter's wrong. The hearing community has the same struggles, but when we're talking about the deaf community, we're talking about their culture. And we have to understand, and we know that things are changing. You know, our deaf culture looks a little different than it did 20 years ago, 50 years ago. We understand that it is different. Culturally, things are different. Technology has had their effect on us. The need to get together to see each other has lessened. That feeling of direct bondness and having roots is not there as much. But when someone has a drug or alcohol problem, it's very shame-based, and it's stigmatized when people look at them. They blame them for having the problem. It's their own fault. They see the behavior, and sometimes it's very obvious with the behavior. You know, if someone is falling down drunk, or if they start stealing things, if they damage property, they can see themselves, individuals see themselves more clearly, and their friends, their community backs off away from them. They don't want to have that within themselves. The community is not understanding that the behavior is a symptom. It's a symptom of a serious, deep-seated issue that is occurring with them. And that there is a reason for the behavior. There's a reason for what they are doing. It's very important that while we're teaching individuals, the community needs to understand as well. And not just talking about alcohol and drugs, but just talking about life in general. I mean, during COVID and the pandemic, there were so many things that were not shared with the deaf community. We didn't have the information. We really need to have it opened up, the information open to us. And we need to understand that stigma and what causes the struggle for the individual who is suffering from SUD. People may be less inclined to mention that, I'm having a struggle. They may know they have it, but they're just not being able to say it, or they're denying it, or they know, but they do not want to be looked down upon. They don't want to hold that stigma that others are looking at them. Again, talking about treatment for deaf individuals, it's a very small group. Why is that? Why does it happen that way? And that could be one big part of it, in my opinion, would be the insurance, And also when you go to that, you go into a group and now you're stigmatized because others are looking at you. And you're not just your individual anymore. You're a group of individuals that are stigmatized. And if you look at the person who's struggling, we need to understand it is a disease. I mean, if we were talking about a person who had diabetes, we would not get away from them. We would not avoid them. We would figure out how to help them with the symptoms with, do you need water? Do you need juice? Do you have insulin? If we're talking about a person who's suffering from cancer, even a cancer survivor, we support them. We figure out how to help them with their disease. If a person has surgery, we want to do what we can to help them. But when you talk about alcohol or drug disease, that's not what happens. They're ostracized. People stay away from them. And basically, what we need to do is provide education, proper education, and information and knowledge. On the internet, we know there's so much misinformation out there that we really need to be able to find those nuggets of truth and understanding and know what is out there. There are some things that are effective, but there are some things that are very ineffective, and we see that on the internet. So we need to know the proper procedures, the proper way to deal with it, and we need to be able to figure out what information is true or not. That's something that we at SAISD helps with. We make sure that the information you have is clear, that it is information that is true information. It's not misleading.
And that's a really important thing that the deaf community, they need to be educated about how to reduce that stigma, how to help people who are struggling feel better about themselves so that they have less of a need to use, that they feel more motivated to get on the journey to recovery. AA and NA meetings, they're, around. Again, they have that negative stigma and some barriers as well. The deaf community is very small, so to see somebody at a meeting like that is kind of awkward. And also, maybe you are working through an interpreter while you're at your meeting. That could cause a bit of a challenge as well. SUD in the deaf community, it is, yes, a life issue, a lifelong. It is active. It's just very hidden. It's out there, but it's not in the spotlight. And a lot of information isn't shared between individuals because people aren't comfortable talking about it. I have reached out to various organizations and people to ask about it, and I always get met with the same kind of, this kind of non-committal answer. So we would love to have more talks and more information sharing, but it seems like things are kind of in the same cycle that we're running through over and over again. And so in summary, I will kind of reiterate what we covered this evening, and then I will open it up for questions from the audience or other comments from anybody as well. Again, I want to give enough time tonight to just kind of inform people, but also have a chance for us to engage. Okay. So if anyone has any questions, please do put it in the chat. Let's see. Okay, here. Did I say that people age 15 to 17 are more likely to use alcohol than 18 to 21-year-olds? No, that's not exactly what my point was. The point was that the younger the person is, the first time that they use alcohol, or when they start drinking alcohol, perhaps at home, they start adding it to their soda, at age 12 or 13, for example, which does happen. An individual who starts drinking at the early age of 12 or 13 is more likely to have a problem with addiction to alcohol later in life because they acquired that sort of brain stimulation early in life. So they are more likely to become addicted than those young people who choose to wait until the age of 18, 19, 20, 21 to engage in drinking alcohol. So those who start earlier are more likely to have problems later in life. So that's why we encourage people to wait so that their brains are more developed, so that their judgment is more developed, and so the physicality of their brain has developed enough to be more tolerable or to tolerate alcohol better. Really, the brain does not solidify until you're 25. Before that, your judgment is still developing, and around the age 25 and older, people seem to have better judgment. And so we encourage people to wait until they're older than the ages of 14, 15, 16. People are a bit more impulsive at that age. I hope that helps answer your question. Next question, question 2. Where are the 4 rehabilitation programs that I mentioned earlier in this discussion? So I believe we have 1 or 2 that are kind of an overlap, but one of them is in Minnesota. Now, I would like to mention that Minnesota has changed recently. In my time to today is very different atmosphere. It's becoming more mainstream. They do still accept deaf individuals, but the signing core of staff is no longer a pillar of those institutions. They're deaf friendly. They still have people who sign, but it's no longer a core of their values. We do have a hearing clinic in Rochester that has 2 women who are deaf that go to the clinic a total of 20 hours per week, or excuse me, that teach coping skills and do screenings and look into relapse prevention skills and things like that. And they teach and help people there learn in their own language instead of utilizing interpreters and English. The 3rd place is in Georgia, Atlanta, Georgia, and is called Caring Works Deaf Hope. Really, right now, it is established for deaf males who are homeless. That might change. Some of their policies recently seem to be up in the air. I don't know much about it, but I know that in Atlanta, Georgia, they do have deaf staff who work at that facility, specifically with, like I mentioned, deaf men. And there is one in San Diego, California, Signs of Life, SOL. And that is under DCS, Deaf Community Services. And they have housing, residential homes there for, again, men. I don't know if they're moving, but today they have the outpatient programs, the intensive outpatient programs there. So those are the 4 areas that you can go. I believe Washington also has, New Jersey used to have, excuse me, but now we're down to those 4 that I mentioned. So yeah, you can check those out if you're interested. Okay. Let me see. Oh, I've got several chats in here. Hold on. So we do we work or enforce the negative stigma? 1 second. What are you doing to work with or overcome the stigma of addiction in online virtual meetings? People can attend the meeting and stay off camera, use an alternative name. Has that made a difference in meeting attendance and options? So there's 2 questions in there. What we're doing here at SAISD, we are continuing to upload information to our sites. We're continuing to provide workshops like we are right now. Currently, we are developing a campaign for our NTID students, and I think we'll also apply it to the community as well. So we're working in different ways to encourage people to take surveys, comprehensive surveys and screenings with tools to see if people are maybe have some sort of problem with drug or alcohol usage. We're also using a hashtag I want to know. So that is supposed to be akin to people's curiosity in the drug and alcohol realm. So we're using that hashtag to spread awareness as well. And there are many, many things that we are doing just to start the conversation, to have an approach of harm reduction. We're not in the business of forcing people to stop using. We encourage them to use less. We ask them what coping strategies they used in the past. And we counsel them in ways that they could perhaps make better choices, even if that doesn't mean completely quitting the substance. And in the past, we were very driven to stop the use of drugs and alcohol, but now that philosophy is changing and we're more focused on a harm reduction approach. So we're really hoping to be able to start the conversation about drug and alcohol use without the stigma, like I mentioned earlier. And again, there are no statistics. COVID, increased access to these meetings, as in like AA and NA meetings, because they were online. They're not limited to your own region. You could join an AA meeting in, anywhere in the country. Maybe you like one meeting and you can stay, or you can switch out to another meeting that you think might fit you better. And so that is going to be continued. And also when we move more to face-to-face interactions, because I do think it's important to have that empathy included during these kinds of talks. Of course, because interpreting services are sometimes not provided, although Zoom, if you have the funds for tech access, meaning like you have your own laptop or you have somewhere where you can use a laptop. There's also some programs that are text only, in which case you don't have to show your face. You can just type into the chat to have discussions, things like that. So if you go onto our website and click, if you remember that QR code that was on the slideshow, you could click and check out our resources page. And once you're there, you can see a list of NA and AA meetings. I think we are still feeding into that list. We're definitely working on it, but it was established there not too long ago. So go ahead and check it out. There's a lot of online meetings there. They are increasing over time now that COVID is hopefully on its way out. So go ahead and look in the resources section of our website for more information on that. Someone asked, are there trainings for this, or is it something we have ourselves before we train others? So there are trainings, like I could host a training, or Deborah Grinthman, she could host one. She's very involved. We've worked together from way back in the day when Minnesota first opened. She was heavily involved with running that facility. So she is a trainer. And we are, of course, willing to collaborate with several entities and provide training if needed or if wanted. We would just need to know the topics. So let me know, and I can, either guide you one way or another. Feel free to reach out. Yeah. All right, looking for another question here. This question asks, what is my experience with deaf people who are professionals, who maybe have advanced degrees, as in master's, PhD, bachelor's, etc., with their stress levels those individuals' level of SUD, does it increase as well to become more serious or more of a problem? There are out there, yes, is my answer. And I do remember that back when I worked in Minnesota, there were several people who would come who were, you know, people who had advanced degrees, PhDs, master's degrees, teachers, college professors, people of all sorts of backgrounds. But one thing that I did notice, and again, in the past, treatment, and still sometimes today, focuses on the whole person, mind and body, both, the connection of thinking and feeling. So we try to encourage that connection between the brain and the body. So people who are, you know, intellectual professionals tend to be people who have a hard time connecting that brain to the body. And sometimes they have a hard time understanding the treatment process because they lack that mindfulness to apply and allow themselves to change and allow themselves to broaden their understanding. Many of them struggle with it. And mind you, this is not all of them, but I did notice that trend. There are those who tend to, perhaps they don't have a lot of information. They're typically more accepting with new information. So you can counsel somebody about a different approach, and they may not understand that, you know, their behaviors are linked to it. We have 1 or 2 people from Canada who would come, you know, for several months, and they were very language deprived. So instead we used art to encourage that mind-body connection. They did leave, and, you know, I hope they're doing well. Unfortunately, after a person leaves our treatment center, there is no way to follow up with them. Addiction has a low rate of success, or excuse me, recovery has a low, sobriety has a low rate of success. So we have a, it's possible that that people will relapse occasionally. So that should become part of their recovery journey, is to realize that that process of working through the feeling of wanting to just have another drink or have another experience could perhaps make them relapse in the future.
And to help them understand that they may not have the strength to do it on their own. And there are people who won't go anywhere until they're court ordered to go. So there's a lot of challenges to opening everyone's mind to understand the truth about themselves and who they are, the inner workings of their own soul. There sometimes takes several times of attempts of treatment, but everyone is very different. Some people could be successful in the first try. The next question is, if we would have more deaf social workers or therapists, would it be more helpful for the deaf community to come out and talk? I believe a severe lack, not just a lack, a severe lack of working professionals, therapists, social workers, psychologists, whoever within the mental health teams. We have a severe lack of them working with the deaf community. For example, here at NTID, National Technical Institute for the Deaf, we hire counselors and academic advisors. We need 2 more individuals. We have the vacancies. We have very few applicants. As well, we hire therapists who sign. You know, it doesn't matter hearing or deaf for us, as long as they have fluency in signing. We have almost no applicants for those. So the academic part, the training provision, the education to those individuals is lacking. Gallaudet has their counseling department, and even that is starting to decrease. So yes, we do have a severe shortage of professionals within our field. Myself, I'm certified as a counselor for addiction, have been for a while, but that's not my field. That's not what I'm doing right now. What I'm doing right now is being the director of the program. So I'm not out there providing those services. There are not many like me. I do some. There are not a lot of people that are certified throughout the country. So if we had more of those individuals who were able to understand the challenge, were able to maybe work a little bit in one area while they work in the other, and then grow the field, they can change to that. And that's over time, we can have more individuals that are in the professionals in there. You know, I can see that it's almost time for us to stop. So I'm going to turn the PowerPoint off. Oh, one more question. The question is, can any deaf individuals from Florida join any NA or AA meetings from your resources? If you look at our resource list within the program, you can look at those. You can see that there are lots of them. Remember that most of them are Zoom, maybe all of them are on Zoom, but they don't know where you're coming from. You join and they don't know if you're, what city you're in. They don't know where you're sitting. You don't know where the Zoom meeting has originated from. They could be from all over the world. No one knows where each other's from. So you have the ability to join any meeting that's out there that you would like to, as long as you're joining. Face-to-face meetings, again, that's something that you would go to, you know, but in the rural areas, there are not a lot of options out there. With us, the advent of using Zoom has increased the contact with individuals. You know, there are not rules out there other than the meeting is closed, that whatever happens there stays there. There are some meetings that are open to everyone, but you can try and find which meetings are open for anyone to join or which are closed to a specific group. So we're going to use this as the last question in relation to hearing providers within the field, treatment services, psychology, psychiatry, counseling. If we're talking about a hearing program, but we're talking about alcohol and drug addiction, what is the best way to help them provide services to their community, to the deaf community? That's what we do. We try and contact those individuals, those organizations, those offices. We try and get involved with them. We try to help them with the meetings. We have, you know, meetings with them, trying to make them see this, that, you know, we're there. We present ourselves. They can't avoid us. So, and often what happens is, for example, a halfway house. If a deaf individual goes into a halfway house, he's one person by himself. He's lost. They're resistant to bringing in an interpreter. There's a lot of issues. So how can they succeed if they're not getting the services that they're going to? We do provide that information to them. We do reach out to those offices, organizations, and we do work with them, especially here in the local Rochester area and the treatment area. We go and talk to them and talk to them about providing services, talk to them about the community and how to make sure that things are accessible. Okay, so it is time to stop. Thank you so much for coming. I wish we had the ability to meet each other and see everyone, but we know that we're not. Please feel free to email us. You can get on our contact list. The PowerPoint will be available as well. I don't see my email there, but we will make sure that the email is out there. Thank you. Good night and have a good evening.